Hello, my name is Ajit Samuel, MS Resident Batch of 2021. I warmly welcome you to the Aravind iCare system and to this module on the protocol to be followed during physician posting. You may be posted as a physician either in the free, camp or paying hospital. I'll be talking in detail about the role of a resident during physician posting. Without further ado, let's get right into it. Roles and responsibility of a physician. Now these points are common to free, camp and paying hospital. Number 1, to elicit proper systemic history from the patient. Number 2, to carry out general and systemic examination of the patient. Number 3, to ensure continuity of intake of medications, especially before and after the surgery. To avoid unnecessary cancellation of the procedure. To ensure appropriate management of systemic conditions and give fitness accordingly so as to avoid complications such as pulmonary edema, stroke, myocardial infarction or anaphylaxis. To monitor patients with high-risk comorbidities intraoperatively and to manage emergency cases in the ICU. So first, I would like to begin with the roles and responsibilities in free and camp hospital. Documentation of history, documentation of vital parameters, examination and investigations, identify high-risk patients who require monitoring intraoperatively, and to initiate referral for patients with uncontrolled high-risk comorbidities. Now I will talk in detail about each of these points. Always ensure that the case sheet or rule slip in front of you belongs to the patient you are examining. Make sure that you use the ID card and MR number of the patient to open the EMR. So documentation. We start with documentation of systemic conditions, investigations, especially of ECG or any additional blood investigations that have been done, systemic evaluation and fitness, and finally, after giving fitness for the patient, sending them to counseling. Let us look in depth about systemic conditions and the history to be elicited. In diabetes, duration and medication, especially if the patient is on OHA or insulin. In hypertensive patients, the duration and medications that they are taking. In cardiac patients, duration, medication, and also if they have undergone any cardiac surgeries and the details regarding those surgeries. Allergic history. Now this is very important with regards to drugs or food. Seizure history, past surgical history, especially other ocular surgeries. Renal failure and dialysis. So details regarding site of AV fistula is to be documented, type of dialysis, duration and frequency with which they are going for dialysis. Asthma, medication history. If the patient is on nebulizer or oxygen support, it should be mentioned in the case record as well as informed to the OT and ward. And other systemic conditions such as active TB, if the patient is HIV positive or other seropositive conditions. The physician has to ensure adherence to medication. For example, in diabetic patients, OHAs are to be omitted on the morning of surgery. This has to be completely and explained to the patient so that they are able to follow this instruction on the day of surgery. If the patient is on insulin, 1/3 of the dose is allowed on the morning of surgery. For hypertensive patients, they are to continue their regular medications. For cardiac patients, they are to stop warfarin 3 to 5 days prior to surgery, preferably 5 days before surgery. A point to note, in Aravind Eye Hospital, we do not advise patients to stop aspirin or clopidogrel for cataract surgeries. For patients with CKD, dialysis is to be done 1 day prior to surgery. During your physician postings, kindly make sure that if you are seeing a patient before surgery and they have not completely finished their dialysis, they are to be sent for dialysis and the patient is to be taken up for surgery 1 day after. Asthma, regular medications to be continued. For foot ulcer, now this is a point to be checked during systemic examination. Look for any signs of sepsis. If the patient might go into septic shock, please defer the surgery. If the patient has a small active ulcer or healed ulcer, this patient can be taken up for surgery as the last case in OT. Seropositive patients like HIV, hepatitis B and hep C. These patients can be taken up for surgery provided they are the last case in OT and the surgeon has to be informed. History of drug allergies. To check for documentation of any known allergies, and in case of known drug allergies, arrange to give xylocaine test dose in the block room. Injection test dose is indicated only for drug allergies. Test dose is not indicated if the patient has food allergies or skin allergies. Ensure documentation of the vital parameters. This is very important for every patient that you see during your physician posting. The vital parameters have to be recorded. The BP, the pulse rate and the SpO2. The correct values are to be entered in the EMR. Ensure ECG is taken for patients with systemic illness and patients aged above 60 years. Document the ECG findings in the EMR. An X-ray, ECG and echo has to be checked, especially for patients undergoing general anesthesia. Avoid checking BP in the arm with AV fistula for dialysis patients. Examination and investigation. So conduct a thorough general and systemic examination of every patient that you see. Look for any signs of sepsis like I previously mentioned, pedal edema, signs of volume overload, basal lung signs, and document in the EMR if any of these findings are positive or if they are negative. Ensure that if patient is on dialysis for renal failure, they have to undergo dialysis 1 day prior, as I previously said. Appropriate investigations to be done pre-operatively. For diabetes mellitus, FBS or PPBS or an HbA1c is mandatory before giving fitness for that patient. Cardiac illness, ECG and echo necessary. To look for pedal edema and any signs of volume overload. For hypertensive and renal disease, RFT, and patients on anticoagulants, PT-INR is to be checked. Validity period. Now this is an important slide which tells us the validity of the various investigations done. If properly followed, this will help save a lot of time for the physician as well as for the patient. So for the diabetic patient, you can see blood sugar values are valid for a period of 1 week, HbA1c for 3 months, urea creatinine 3 months, ECG 3 months, echo for 3 months, and physician fitness if you've seen this patient less than a month ago, and if the physician has given fitness for this patient and for some other reason the patient's own preference, the surgery is deferred, then this patient need not get fitness once again. For cardiac, renal or patients on dialysis, blood sugar is valid for 1 week, HbA1c for 3 months, urea creatinine is for 1 month, ECG 3 months, echo is for 1 month, and physician fitness is just 1 week. So make sure that when the patient comes to you and when you open the EMR, go back and see if there are any other updates so that you can save yourself some time. So the physician is to identify high-risk patients and document the same in EMR. So some systemic conditions that require monitoring intraoperatively in free and camp OT will be cardiac patients as well as CKD patients under dialysis. Initiate referral for patients with uncontrolled high-risk comorbidities such as cardiologist's opinion is needed in the following cases: severe left ventricular dysfunction, ejection fraction less than 30%, recent MI within 3 months, left bundle branch proc in ECG, heart rate greater than 130 per minute, and a nephrology opinion is indicated in patients with creatinine greater than 7 and volume overload. Now, I hope that gave you a clear idea of what a physician is expected of in the free and camp hospital. Now, let us take a look at the role of physician in the paying hospital, especially the paying OT. Now, it is very similar to free and camp hospital with a few differences, like monitoring vitals of high-risk patients intraoperatively throughout the procedure, and to ensure that high-risk patients shouldn't be made to wait for a long time in the block room and should be shifted to the OT as soon as possible. We'll start with documentation of vitals, very important. Next, monitoring the vitals of high-risk patients intraoperatively throughout the procedure. The patients should be checked at regular intervals. The patients should be auscultated in the waiting area before shifting to the OT. if in case anesthetist opinion or supervision is required, to inform anesthetist regarding the patient details prior to the surgery. Intraoperatively, after shifting the patient, inform the surgeon regarding the patient's systemic condition. Reassure the patient and talk to him and tell him if that he has any complaints to open up and speak about it during the surgery. Monitor the cardiac and respiratory status and note the vitals on the monitor case sheet which is displayed in front of you. In the event of an emergency, the physician is to provide immediate first aid and life-saving care to the patients, which may be preoperatively, intraoperatively, or postoperatively. And finally, after stabilizing the patients, in certain emergencies, you can call for help to the anesthetist or MD physicians who are available. Any signs of pulmonary edema leading to a fall in SpO2 less than 85%, not improving with oxygen supplementation, in the event of a cardiac arrest, sudden tachycardia, sudden bradycardia, or anaphylactic shock. Now always remember, these are not the only instances where you can call for help. In any situation where you are unsure how to handle the patient, after stabilizing the patient, you can always depend on the MD physician or the anesthetist who are in the OT for help. With that, we come to the end of this module. I hope that you are now adequately to carry out the duties of a physician to the best of your abilities. Thank you and all the best.